As men age, the risk of having a prostate problem increases. Except for skin cancer, prostate cancer is the most common cancer for men. Correspondent Erica Moffett is here to share a patient story with us. Erica.
Thanks, Amy. John Chudovin followed the rules. Every year, he went for his PSA test. As his numbers went up, he knew something had to be done. Here's John's story.
Grew up in Reading, Pennsylvania. Went to school, several schools, and went to work for the U.S. Army in Washington as a civilian, but it was during Vietnam.
After years of living and working in the D.C. area, John Chudovin and his wife eventually put down roots in Gettysburg.
We've been here just about 34 years, and I retired 10 years ago.
They've come to love the area and say it was a great place to raise a family.
We have 3 kids. My son is 46, our daughter is 44, and we have another daughter, 39.
These days, John enjoys hunting, taking care of his car, and spending time with family.
Somebody always has a band concert, a basketball game, a volleyball game, something going on at school.
About 5 years ago, John was enjoying his retirement and everyday life until his health became a concern. He was already in the care of a urologist who had him coming in once a year to check his PSA, prostate-specific antigen.
I'd have that every year, and everything was pretty good. And then my PSA started to go up and up. My urologist recommended a biopsy. I had biopsy, and it wasn't cancer. He said, I want to do another biopsy in 6 months, though, rather than a year. That one was.
After the second biopsy, John was diagnosed with prostate cancer.
Until somebody tells you you have cancer, you have no idea how it feels. It's surreal.
John's doctor recommended radiation to treat the cancer, but his middle daughter insisted he get a second opinion.
So she told me, she said, you spend more time looking for a car than you do for a doctor.
When our daughter called us and yelled and screamed and carried on, she made us think a little bit, and it worked. Our family doctor advised us to go to Hershey and to see Dr. Rahman, which we did.
When we got the MRI, we saw there were multiple areas in his prostate that were really suspicious for cancer.
Outside of John's cancer diagnosis, he was considered a healthy individual with a long life expectancy. So Dr. Rahman recommended he have surgery to remove the cancer. John was hesitant, but his wife pushed for the procedure.
Why are you waiting? Why are you trying to put this off? If there's something in you and they want to take it out, why do you want to wait? You want to get it out as quickly as possible.
So Dr. Rahman performed John's surgery. Today, he is cancer-free.
I always use the term cautiously optimistic. So yes, I mean, he's 5.5 years out from surgery. His PSA numbers are 0. Clearly, as you go further and further out from an operation and your numbers stay undetectable or 0, the likelihood that this cancer is going to come back is lower and lower.
So far, so good. There's no, and I had a little bump in the road that could have been the end of the road if I didn't do what I do.
John said he's very thankful his daughter pushed him to not sit back and wait. Dr. Rahman told him his cancer was very aggressive. Amy.
Okay, thank you so much, Erica. Well, joining us now is John's urologist, Dr. J. Rahman, the chief of the Division of Urology at the Penn State Cancer Institute. As we saw in John's story, regular prostate screening, I should say, it worked.
Yeah, I think you're right, Amy. So John had a fairly aggressive type of prostate cancer, despite not having any symptoms. And for most men, when they're diagnosed with prostate cancer, you don't have symptoms until relatively late in the disease process. And those symptoms include bone pain, weight loss, urinary tract obstruction. The goal of screening is really to find men before they become symptomatic at an early stage where they may not only be treatable, but hopefully even curable. And prostate cancer screening is really quite straightforward. It involves a blood test called PSA, or prostate-specific antigen, and a rectal exam to feel the prostate for any lumps or bumps or abnormalities. And an abnormality or irregularity of either your blood test or the rectal exam should hopefully prompt a conversation between the patient and their provider or their physician about the merits of a prostate cancer diagnosis.
Now, what happens when a patient is diagnosed? Like, where do they go from there? Are there national guidelines on what to do?
Yeah, I think one of the most common misconceptions is that prostate cancer is a single uniform or homogeneous entity. And in fact, if you look at the over 200,000 patients diagnosed annually, you have a spectrum. Some are low risk and not aggressive. Some are higher risk with more aggressive cancers. And when we assign different risk groups, that's based on easily measured things. Your PSA test, your rectal exam, what your biopsy showed. The American Urologic Association is our national guidelines, and it advocates putting patients into different risk groups. And why do we do that? So we can individualize treatment. So a patient with low-risk prostate cancer may be fine with surveillance or observation, and somebody with high-risk prostate cancer may need single or maybe even multiple therapies.
And we saw in John's case, it was worth talking more about and figuring out what was best for him. Any particular research about prostate cancer that the Med Center is working on right now? Excuse me.
Yeah, I'm really proud of the fact that Penn State Urology and the Penn State Hershey Cancer Institute is involved in the Pennsylvania Urologic Regional Collaboration. This is a statewide collaboration, but we're the only group, private practice or academic, in the central Pennsylvania area that's participating in it. And the goal of this is to improve the quality of care for men with prostate problems and prostate cancer. And we do this by looking at patients that we take care of and asking very critical questions. Can we make biopsies safer? Can we reduce the morbidity of prostate cancer surgery? Can we eliminate imaging when we don't need to image patients with low-risk prostate cancer? And can we survey those patients with low-risk cancer that maybe don't need treatment and may have side effects from their treatments? I'm really proud of this work because it affects not patients necessarily in the future, but those that are coming to see our group today, tomorrow, and the next day.
It's immediate. That's really
exactly
good
right.
information. And then really quickly, before the show, we were talking about like, hey, you have a beard this time. You don't always have a beard when you're on ABC 27. Explain what you're doing here.
Yeah, so this is part of the No Shave November campaign. It's a men's health initiative. It's really geared towards increasing awareness of men's health problems, sometimes cancerous, like prostate cancer, testicular cancer, and sometimes not. We've been very fortunate to partner with Mid-Penn Bank over the last 2 years on a fundraising campaign to increase awareness and increase research dollars that really help us support our initiative for the collaborative that I discussed. And I really think that this sort of partnership is very beneficial. It's a community partner invested in people in the area and doctors and providers who are trying to improve the quality of care for men in this region.
Very good, and we're actually coming up going to learn a little bit more about that campaign you were talking about. But for now, let's go over to Deborah Pinkerton, because as part of this special, we have a web chat going on, and Deborah's here with some viewer questions. Deborah.
Thanks, Amy. As you can see, the doctors are here busy answering email questions right now at abc27.com/prostate chat. Joining us right now is urologist Dr. Matthew Cake. Thanks for being here. One of these viewer questions came in. It says, my older brother got prostate cancer when he was only 52. Although I'm only 44, should I be screened?
So having a family member with prostate cancer does increase your risk of having prostate cancer. The AUA currently recommends screening in patients that are 55 to 69 years old, but in patients that have a first-degree family member with prostate cancer, we do recommend screening earlier.
Here's the second question. I'm 76 and had my prostate removed 10 years ago. I've had a PSA test every year since. All show negative. Is this yearly test still needed?
The answer is yes. Follow-up after a prostatectomy usually occurs every 6 to 12 months and consists of a PSA test. After 5 years, we generally move that out to once a year, but we do recommend continued follow-up because the cancer can come back.
Okay, Dr. Cake, thanks for being here. And you can submit your questions. Go to abc27.com/prostate chat. We'll send it back to you, Amy.
Thank you so much, Deborah. Well, coming up next, we're going to talk to the president and CEO of Mid-Penn Bank about No Shave November fundraisers. That's next on this special Good Day PA on ABC 27. Welcome back. Dr. Rahman remains on set with us, and we're also joined by Rory Retrieve, the president and CEO of Mid-Penn Bank. You're going to tell me about the fundraiser that you have going on right now.
Yeah, so 100% of the money that Mid-Penn Bank ultimately contributes to the Penn State Cancer Institute is going to come directly from the pockets of our own employees. So we have 270 very generous employees at Mid-Penn Bank, but we wanted to find a way to stimulate that generosity. So last Friday, I issued a challenge to them that if they could raise $11,000 or more by November 1st, that they could all dress down throughout the month of November and I would remain unshaven throughout the month of November.
Okay, so we're going to
So-
see some progress this month.
A little
from
bit,
you.
yeah. So this is second day growth. I think Dr. Rahman, he cheated a little bit. He started
He
earlier.
started
but-
early. Yeah, he started early. Talk about, this is the second year you're doing it. So
It
talk
is.
about how much you raised last year.
So we raised $11,000 last year. We gave Dr. Rahman a check at the end of the process, and I think he was very appreciative of that amount. I think it was
Cool.
substantial and meaningful. And but at Mid-Penn Bank, we like to set the bar higher. We like to do more. So I am pleased to tell you that at the end of this month, we'll be giving you a check for $15,000.
Wow, outstanding.
Outstanding, you said. I mean, how important are fundraisers like this to the research and the work that you're doing?
Well, I mean, look, the federal funding for research is going down. There's not a lot of money at the National Institute of Health, National Cancer Institute. So we rely on partnerships like this in order to get the research dollars to ask the questions. We have to ask the questions, we have to answer the questions to treat patients better. So, you know, contributions and support like this is frankly invaluable. Thank you.
It's our pleasure.
And speaking of contributions, the public can get involved too. We're going to put information on your screen as to how you can donate for No Shave November. You can send a check to the address on the screen, or you can go to that website and you can contribute there. Thank you both for coming in today. Good to have you. Now, correspondent Erica Moffett is back to share another patient story with us. Erica.
Thanks, Amy. Well, when you hear about prostate health concerns, you may think of cancer, but actually about 75% of the people with prostate problems have issues not related to cancer. John Goodling is one example. Here's John's story.
I taught school for 31 years. I coached football for approximately 30 years, and I coached track for about 25 years.
John Goodling played or coached sports for most of his life. In addition to sports, John is a family man. Originally from West York, John and his wife raised their family in central Pennsylvania.
We have 3 daughters, and we have 5 grandchildren.
Over the years, John has dealt with some health problems, including some heart health issues. John had to undergo surgery, but according to Dr. Joseph Clark, a urologist at Hershey Medical Center, that is actually what led to his prostate problem.
His story started after he had a device implanted for his heart. And after that procedure, he was unable to urinate.
Because John started having problems urinating, he was given a Foley catheter.
We pass this through the penis into the bladder, and then we blow up the balloon. And because there's a balloon, this won't fall out. And the urine drains through the hose connected to a bag.
While he had hoped to only have the device for a short time, John ended up wearing it for 8 months.
We were almost isolated. I mean, we could visit close, but you didn't really take trips or do anything because you always had to have, he always had to have his bag on.
John was referred to Dr. Clark for help.
We recommended that we do a common procedure called transurethral resection of the prostate. That's an operation where we pass a special instrument and chip away at the prostate to make a bigger channel.
The surgery was a success, and John felt like he had regained his freedom.
That was one of the best feelings I've ever had, was being able to go to the bathroom without that bag.
We just felt like we could go places and do things without worrying about, you know, where we were, and yes, it was great.
John and his wife, Charlotte, have been married for 57 years. Although John does have other health problems, getting around each day is now much easier. We'll be right back.
Welcome back. Joining us now, Dr. John Knadler, a urologist at Hershey Medical Center. Now, besides prostate cancer, what are some other issues with the prostate?
Well, as mentioned earlier, the majority of prostate-related problems are non-cancerous, and probably the most common is benign prostatic hypertrophy, which is just an enlargement of the prostate resulting in blockage. As men age, they can have difficulty emptying their bladder, slow urinary stream, hesitancy, urinary tract infections, or even end up in frank retention needing a catheter.
Well, talking more about that, BPH, how do you treat it?
Initially medication, that's the most common, and most men will respond to medication, but some will either have side effects and not tolerate it or go on to progress and need surgery. Transurethral resection of the prostate's been the gold standard for decades, but at Penn State we actually have a new offering available, something called HOLEP, holmium laser enucleation of the prostate. If you imagine a prostate's like an orange, we peel out all the fruit and we leave the rind behind. So it takes it all the way down to the capsule or the shell of the prostate. It's as thorough as we can be without doing a total prostatectomy and removing the whole prostate.
So everybody who is suffering from BPH, are they a candidate for HOLEP?
The majority will be. If you're a candidate for a TURP, if you're a candidate for surgery, you'll usually be a candidate for HOLEP. Some patients, it's the ideal treatment. It can handle a prostate of any size, and so for particularly large prostates, it works well, and it actually results in some lower retreatment rates down the road.
Okay. So it's always encouraging on our show. We always present the problem and the solutions, which is fantastic and gives a lot of hope to a lot of people. Thank you so much, Dr. Knadler, for coming in today. We'll be right back. As today's ABC 27 prostate chat continues, we check in with Deborah Pinkerton.
Thanks, Amy. Doctors here have received more than 15 questions, so they are busy answering your questions. Go to abc27.com/prostate chat to submit a question. Dr. Kaag, urologist, joining us for a couple more questions. I've seen ads for dietary supplements that claim to help with prostate problems. Do they work?
So there's a lot of supplements out there and they claim to do a lot of different things. The best suggestion I have for your viewers is before they start taking anything, I would check with their doctor. Some of these are respectable, some not so much.
Another question, is there a diet I should follow to help prevent prostate problems?
Researchers have looked at a lot of different dietary components trying to figure out what might be preventative. Some substances like lycopene, which is in cooked tomatoes, may be helpful, but nothing's clearly beneficial.
Okay, and once again, probably check with your doctor?
Absolutely.
Okay, great. And you guys will be here until 1:30 answering questions. So you can submit your questions until that time. Dr. Kaag, we want to thank you for joining us, and we will send it back to you, Amy.
Thank you, Deborah. I thank the team at Hershey Medical Center for today's special program, and of course, the patients for sharing their stories with us. And again, this reminder, the conversation continues online, as Deborah said. The prostate web chat will run until 1:30 this afternoon. And also, here is how you can submit donations for No Shave November. You can send a check to the Penn State Cancer Institute in Hershey. On the memo line, you want to write MPB, No Shave November. And again, you can still get your questions in to our experts this afternoon. Visit abc27.com/prostate chat, and that again until 1:30 this afternoon. Thank you all for watching today's show. Hopefully you learned something. As always, make it a good day, PA.